You need to take everything in your house that is breakable, that you love, and put it in the attic until the kid turns 16, because otherwise it's all going to break, right? You know, they don't understand that. You've got to do this. You have to do this. If you like, if you know, there's something that you care about, sure. You don't understand that when you go to cook something on the stove, don't keep the handle out, turn the handle in. Something as simple as that. They don't understand that. So it's a very, very difficult thing, and it's a huge challenge for y'all to deal with adolescent moms and adolescent dads as well. You want to encourage them to take prenatal vitamins, to get prenatal care. And a lot of times the only way you can get them to take the vitamins and to get the care is not to talk about the baby, but to talk about them and focus in on them, because that's all they care about, really. They're still at that point in time where that's what they care about. So, you know, it would be better for your health. It would be better for you can get your figure back right, faster if you do this. You see, you have to turn it so that it's focused on them, not the baby. They care about the baby, but it's still a very unrealistic sort of an idea. You want to definitely teach them about labor and delivery. You want to teach them that it hurts. Okay, I had a 14-year-old in labor screaming, "It hurts, it hurts, it hurts, it hurts. Do something, it hurts." And I said, "Yeah, I know it hurts. That's why they call it labor, not picnic." You also want to teach them about infant care, okay? Taking care of the baby, that's such an important thing. Teach them simple stuff like, what do you do with the umbilical cord? All right? How do you bathe the baby? Yes, pick the baby up. You know, mommy says, don't pick the baby up. You will spoil the kid. No, pick the baby up. Baby has only one way to tell you there's something wrong, and that's from crying. And so when the baby cries, pick him up. Find out what's wrong. Because he's guaranteed it's either because he's hungry, he's wet his diaper, or pooped in his diaper, or he just wants you to pick him up. That's all. It's one of three things. Very easy. Very easy. But if you don't know the expectations and you don't know this about babies, what happens? Then you end up with child abuse cases. All right, let's talk about labor and delivery. I know you all been waiting all day for this, huh? Okay. We're going to talk about the passenger, the passageway, the powers, the placenta, and the psychological response. Hey, we're going to have some fun here. Okay, let's talk about the passenger, which is the fetus. Remember that the fetus, the largest part of that baby is the head. Yes, the baby is all head, isn't it? It's all head. So the largest part is the head, and this head must be able to pass through the pelvis. The position is the relationship of that presenting part to the maternal pelvis. Okay, so you all know about LOA, ROA, LOP, ROP. Okay, I'm going to stand up here now. I'm going to be the fetus. Okay, I'm the fetus. I'm going to go into this little fetal position now. Right here I go. I'm in this little fetal position. Now, if I am LOA, that means I'm in this position. My occiput is on the left side of mommy. Yes? And I am now looking at my mommy's right butt. See? I'm LOA. Got it? This is left, this is right. I'm fetus. I'm in the fetal position. I'm in this position. LOA, left occiput. This is my occiput. Left side of mommy, anterior. This is the anterior portion of mommy. This is mommy's butt right here. Okay? So my left occiput is this way, anterior, and I'm looking at mommy's right butt. Now, ROA. I am now ROA, right occiput. Occiput's in the right side of mommy, anterior, and I'm looking at mommy's left butt. Got it? Sure. Now, I can't do the other way because I'm not double jointed, but you get the idea. Okay. All right. Okay. The presenting part is the part that enters the pelvis, and you've got the cephalic, which means head first, you've got the breech, which means feet first, and then you've got shoulder. Now remember, with breech birth, it's really important that when those legs come out, that you got to get the head out pretty quick before the cervix snaps shut. Okay? Like I said, these perinatologists were incredible. This one doctor was amazing. She's absolutely incredible. She could deliver the baby, and the feet would come out first, breech, and she'd just go pop, and here the baby would come right out, and then the cervix would clamp shut right behind it. because you don't want somebody to clap around the baby's throat, especially breech presentation. So she was very, very good. So the problem and the concern with the breech presentation is not only getting the feet out real quick, okay, but getting the feet out and then getting the head out real quick before the cervix clamps shut. Okay, so that's a really important thing. There's a thing called Leopold's maneuvers, and you all know this. Leopold's maneuvers is when you palpate the abdomen. The examiner palpates the abdomen of mommy, and you can palpate and feel for the fetal heart and the stomach, the bottom, and then you can also feel the arms and the fingers. So you're essentially determining position with Leopold's maneuvers. You can also do it by vag exam. Of course, you would have to have ruptured membranes to do this. And what you can do is if you put your fingers up doing a vag exam, and if she's somewhat she has to be dilated as well, okay? At least 2 centimeters dilated. So she's about 2 centimeters dilated. You can put your fingers in and kind of feel if there's feel for the suture line and the fontanelles, and then you can tell whether she's ROA, LOA, or whatever. But she has to have ruptured membranes. Okay, fetal assessment during labor. Well, you got to monitor those fetal heart tones. And we do this through external fetal monitoring. We can do it through internal fetal monitoring as well. We can do it also from fetal blood gases, but we generally do fetal blood gases after birth, and we take the blood gases right from the umbilical cord. We don't do fetal scalp sampling anymore, though nclex still asks you about it, but we really don't do that anymore. And we do watch those fetal heart patterns a whole lot so that we can monitor also for fetal distress. Okay, let me go ahead and put this low-tech projector up so we can talk about fetal heart tones real quick. Do you all know how to tell? This top diagram here, this top bump here, that's mommy. Okay, that's the mommy's contraction. All right? This one down here is the fetal heart tone. So essentially, this is a good picture because this is an early deceleration. The deceleration of the fetal heart rate should coincide with the mommy's contraction. In other words, when mommy contracts, as she reaches the peak of her contraction, the baby's heart rate should reach the lowest it was possibly going to reach. This is an early decel, and this is good because it shows that the baby is simply responding to the contraction. Okay? If you have a condition of late decelerations, that is not good, and that means a problem. That indicates some form of a problem. If you have decelerations that don't pay any attention at all to mommy's contractions, in other words, there's absolutely no correlation at all, that's big time trouble, and we'll get into exactly what each one means in just a second. Okay? Now, when you're counting contractions on mommy, because you don't count baby's contractions, baby stuff, but you do count mommy's contractions. Okay, if you're counting frequency, in other words, how often these contractions are occurring, then you're counting from the beginning of one to the beginning of the next. If you're counting duration of a contraction, then you're counting from the beginning of one to the end of the same one. If you're counting intensity, then you're measuring this level. Okay, so how high and how intense that is. All right? The normal fetal heart rate is what? Between 120 and 160. We like those things. If it's less than that, we have a little bit of a problem, and we get kind of nervous about that. Okay, here's what we like to see during labor. Very happy babies. Okay. The fetal heart rate should be 120 to 160. We like beat-to-beat variability, which simply means that fetal heart rate should have squiggly lines on it. Okay, it shouldn't be smooth, it should be squiggly. So beat-to-beat variability is very, very good. Okay, the other thing that we like to see and we want to do is we want to put an external monitor on mom. So we put a toco transducer on the mommy's fundus, and we can also use a fetoscope. And a fetoscope is something that has, it looks like the stethoscope, but it's got a big, the actual bell of the stethoscope is right, it's on your head. So we can use a fetoscope as well to determine the fetal position. The other way we can do it is by using an internal scalp electrode. Now, for us to utilize an internal scalp electrode, which means we actually hook it onto baby's scalp, is obviously she must be dilated at least 3 centimeters, and she must have ruptured her membranes, because otherwise we can't feel the baby. And we're certainly not going to rupture the membranes. And the fetal head should also be engaged. because that's the only way we can actually ascertain. Okay, so if the fetal head is engaged, cervix is 3 centimeters, we'll go ahead and put a fetal scalp electrode in. So, I talked to you about fetal blood gases, and I said to you that we generally do that from the umbilical cord, and essentially what we're trying to find out after the fact, if there was any acidosis at all, and if there wasn't, the baby might have been hypoxic for certain periods for a period of time in utero. We want to watch for fetal heart patterns, and I just went over early decels and late decels. Okay, early decelerations are good. They're very reassuring. It simply means that there's a head compression on the baby. A late decel can occurs late in the contraction, and it indicates the possibility of a uteroplacental insufficiency. In other words, there's not enough oxygenation getting through to the baby. So it's a UPI, or uteroplacental insufficiency. Late decels, if you see them, you turn the mommy over onto one side, give her oxygen, and if she's on PIT, slow it down. Okay, so that's how you take care of late decels. Variable decels, which I told you we did not like, we really hated that. That's umbilical cord compressions. There's no correlation between these decelerations and mommy's contractions. It's not ominous, but it requires us to implement interventions immediately. And essentially what we do is we change mommy's position right away. We give oxygen and we assess for a prolapsed cord. Now, I had a mom one time that indeed did happen to her. She was actually going through early decels really nicely, and then she went from early decels to boom, variables. Okay, and it was just, we were watching her on the monitor, and she went from nice early decels, right away to variables. We went in to check, and when we went to look at in her vaginal area, there was this nice shiny white cord that was hanging out, and was the baby's umbilical cord. Okay, it had slipped out. So we called the doctor. I had to cover the umbilical cord with some sterile gauze that was soaked in sterile normal saline, and essentially I was picking up the umbilical cord because I wanted to relieve the pressure. Ended up throwing her on the stretcher with me sitting between her legs, okay, holding onto this umbilical cord, and we're going off to the OR this way. So. Now, we do not like fetal distress. I don't like babies when they cry, except when they're born. When they're born, I want them to cry all the time because it tells me their lungs are nice and healthy. With fetal distress, that means the fetal heart rate is unstable. What we don't like is to see fetal heart rates dropping like to the 110s, okay? We don't like it. 120 to 160 we really, really like. Over 160, well, temporarily is okay, but we don't like it to stay up there either. Okay, we don't like those kinds of things because it signals problems. Another sign of fetal distress is meconium. If the baby is born, when the rupture of membranes occurs and there's meconium, okay, then sometime, somewhere along the line in that pregnancy, the baby suffered some form of distress because that's the only time that he will pass out meconium. Okay, so if there's meconium, that means the baby was in distress and that's a problem because why? He could have aspirated meconium, right? So we have to get respiratory therapy there at the birth. If that happens, then the prolapse cord is the third thing also that we're going to talk about. And if that happens, you're going to cover it, like I said, and prepare for emergency C-section. All right, let's talk about the passageway. The passageway is the shape and measurement of the maternal pelvis in relation to the birth process. The passageway, let's talk about engagement. Engagement is when the presenting part of the fetus enters the pelvis. It's now station 0. It is engaged. The station is how far that presenting part has descended into the pelvis. At 0, then the presenting part here is at the ischial spine. A positive number means below that ischial spine. That means it's going down. A negative number means it's above and it hasn't really engaged yet. Okay, the cervix stretches and dilates to allow for the fetus to pass through the vagina. And a lot of us don't even know how we did it. Okay, here are the powers that project. Powers are the forces that expel the fetus. Okay, this little kid is with the parachute. Hurry up and come on out, kid. Just don't do that parachute thing. How do you tell the difference between true labor contractions and, say, Braxton Hicks? Well, with true labor, these contractions will increase in frequency and intensity and duration, and they will actually cause dilation. So she will dilate. Okay, it's generally about 1 centimeter per hour. That's generally it on a primip. The frequency, as I said, is the beginning of one contraction to the next. The intensity is the strength of the contraction, so you measure the height of it, and the duration is the beginning of one contraction to the end of that same contraction. There are 3 stages of labor. There's stage 1, which is the onset of contractions until full cervical dilation and effacement. That can take up of the cervix. That can take up to 24 hours in primips. In stage 1, you've got 3 phases. You've got the latent phase, the active phase, and the transition. Okay, let's talk about the latent phasing. Latent phasing, you go from 0 to 3 centimeters. Mild contractions, every 5 minutes to 30 minutes. Mommy's walking, she's joking, she's having a wonderful time, she's giggling and laughing, etc., right? This is fine, life is good, life is wonderful. It's only 10 to 30 seconds and it feels like a mild menstrual cramp. Okay, so what do we do in this particular stage? Well, okay, we assess the fetal heart tones, we check the vital signs. And it says here we give fluids and carbs, so in real life we don't give them anything. In the active phase, well, she's now going from 4 to 7 centimeters. The contractions are now every 3 to 5 minutes, and they're moderate. That's still tolerable. Okay, she's still handling it pretty well. Got contractions lasting between 30 to 45 seconds. Okay, Lamaze is working. Lamaze is working. Rhythmic breathing, yeah, it's working so far. Okay, she has her focal point, and she's looking at her focal point, and her husband is right by her side, and she thinks, oh, this is such a wonderful experience, and I am just so ready for this baby. Okay, and so what do we do in this stage? Well, we monitor fetal heart tones, and if there's any pain, we might give a little Stadol. And at this point in time, she's NPO or maybe ice chips. Like I said, in real life, nothing, right? Nothing. From the second she walks in labor, you don't get nothing, baby. You get an IV. That's what you get. Okay, in the transition phase, it is now every 2 to 3 minutes. It is strong. It is lasting from 45 to 60 seconds. You see behavioral changes. Look what you did to me. Don't touch me. We have to assess fetal heart tones. You're going to stay with the mother and help her. You have to reassure the father, no, she doesn't hate you. She really doesn't hate you. This happens to everyone. And you want to discourage pushing. This is the time when she says, can't you just reach in and pull it out? Yes? Yeah, this is the time. No, we can't do that. This is the time also when she walked in, right? When she first walked in, oh, I'm going to do it natural. I'm going to do it natural. All right. Guess what? This is the time when she goes, epidural! I want my epidural! Give it to me right now! Come on, hurry up! Quick! Here! She wants that epidural, let me tell you. Anything. You give her anything, she'll take it. She will take it. Now, we oftentimes sometimes we'll see those nerve blocks, but we don't see that so very much anymore. But if she does go on an epidural, she cannot be more than 6 centimeters dilated. Can't do that. And you need to tell her that if she gets an epidural, it'll slow down the labor process a little bit. We'll have to monitor for hypotension. Okay, and we'll just have to, so she, at this point, she doesn't care though. You give her the epidural and life is wonderful, right? She is a totally different person now. If you give an epidural, you have to tell her that she has to get about 500 cc's to 1,000 cc's of fluid, IV, before we can actually start the epidural. Stage 2 of labor. Stage 2 of labor is full dilation and effacement to the birth of the baby. So now she's 10 centimeters and she's 100% effaced. Okay, and so it goes from that period of time until the baby is actually born. What you're going to see here is the progressive descent of the baby's head. You'll see a perineal bulge, and you may see some crowning also. When you start seeing hair, then it's time to push. Before that, you don't push. Okay, when you see hair, you push. Okay, and we usually go, mommy's hair is black, daddy's hair is black, red hair. Not a problem. What are some of your interventions here and there? We got stage 2, where you're going to help the mom with pushing. You're going to get ready to suction the baby. You're going to assist with delivery of the shoulders of the baby, and you may have to catheterize the mommy also, because remember, she doesn't feel it anymore. And point of fact, if you catheterize it, get ready for a precip delivery. Sometimes that can happen, because it's the full bladder that's blocking the baby from coming out. And once you catheterize and take out, 1,000 cc's that she has in there, because remember, she's getting all this IV fluid, right? You catheterize, you get all the fluid out, baby comes pop right out. So you want to get ready to catheterize the mommy. Okay, the placenta. Well, the placenta is something that you got to look at after the baby's born. It may cause a problem if it's not implanted correctly or if it's calcified. It starts to calcify over 40 weeks. Some docs will let them go 42 weeks and then they'll actually deliver and they'll induce or they'll do C-sections. Okay? And with the placenta, what you've got to do is look at it too after it's born, because you have to look at both sides. The fetal side is the Schulte side, okay, the shiny side, and the maternal side is the Duncan side or the dirty side. So you're going to have one side that's kind of dull and one side that's real shiny. Okay, so you got to look at the placenta to make sure that it was a healthy placenta. Because if it wasn't a healthy placenta, then you might end up having to send the placenta for a biopsy and then watching the baby and the mom a little bit more. Okay, baby was born. All right, after the baby was born, how do you know when the placenta is going to be delivered? Well, you'll actually see the abdomen kind of become a big old glob like this. Okay, it contracts up like that. Okay, the abdomen just contracts up, and then you'll see a gush of blood coming from the vagina, and then the placenta, the umbilical cord that's attached to the placenta, there's this little bit of a lengthening. And this is when the doctor generally gives it a gentle tug, and out comes the placenta. Okay, you want to make sure the placenta is intact, like I said. Stage 4 is the immediate postpartum period, and this is when your job is to assess fundal firmness. So you got to massage that fundus, massage that fundus, massage the fundus, and it's not comfortable, but it does help because it helps with the involution of that fundus. You want to also document what? The color of the lochia. Remember, your lochia has to go from rubra to serosa to alba, and as long as it's progressing in this fashion, you're fine. If it goes backwards, you're in trouble. There was a 32-year-old woman, she was an attorney in West Palm Beach, who presented to the ER. She had just given birth 2 weeks before to twins. Okay, she showed up in the ER because she had a sudden episode of vaginal bleed. She went from rubra to serosa rubra to serosa to alba, and then she suddenly had an episode of vaginal bleed, which she thought was just a period, but then the cramps occurred. Then the cramps came. So she showed up in the ER. Her husband wasn't even with her. She just drove herself in to the ER. She had retained placental fragments, and she ended up dying. Yeah, she ended up dying, not from the hemorrhaging, but she threw these microemboli. She went into DIC, disseminated intravascular coagulation, and she ended up dying. So just remember, rubra, okay, serosa, alba, that's good. If it goes backwards, that is not good. You also want to tell them that you're going to make them a nice little ice pack to put in the perineum, because you know it's going to be very sore. Because they either had an episiotomy, or if they didn't have an episiotomy, they just delivered a baby, they might have a laceration. Okay, so just tell them you're going to give them ice. You're also going to encourage the bonding. The bonding process is very, very important. You're also going to check the blood pressure for postpartum PIH, particularly if she had it beforehand. And it would be nice to know this right beforehand. Your psychological response is very simple. It simply is, would you agree with me if I say that the better prepared you are for an experience, the better able you're going to be to participate in it, right? So the more information that you give them, your patients, the better off they are going to be. Somewhere out there, says this guy, I know that there's a girl for me, but where can she be? He's scouring the heavens, isn't he? Mom, Dad, I found her. She's the one for me. She cooks, she's a great dancer, she's intelligent, she loves kids, but most importantly, she loves me. Oh, isn't that nice? He's got Oh yeah, she is my princess and I want you to meet her, mommy and daddy. The happy day arrives and this is, yeah, you like this? It's wedding day. Bottle of champagne. 1 year later, here she is. I've lost my toes. And it's okay. Okay? All right. You know they're going to give birth. They're going to have this is the first baby, so they got to do the Lamaze thing, right? We got to do the Lamaze thing. So, okay, is it pant, pant, blow, blow, or is it blow, blow, pant, pant? Anybody know? No, but somewhere along the line, that's the Lamaze thing. You got to do this thing, all right? And here it is one day, and suddenly, oops, there's something running down my leg. So either I peed my pants or my water broke. So, honey, get the bag, call the doctor, and don't forget my focal point. So I think this is it, honey. There they go. They're running off to the hospital now. This is it. This is it? Please don't tell me to blow through it. It hurts. What focal point? Where's my epidural? And what do you mean I'm only 3 centimeters? I've been contracting for hours. Look what you did to me. Isn't this it? Sure it is. Yes. And we're all identifying so far. I want my knight in shining armor. Where is he? Okay, you promised me that you would never let anything bad happen to me. Yes, where is my knight in shining armor? Yeah, we're all identifying so far. Okay, guys, any guys here identifying? I can't take it anymore. Can't you just pull it out? Is it over? Is it over? Oops, oops, okay. Oh, my baby, isn't he beautiful? Aw, life is better. It's all over now, right? Or is it? No, it's not. No, it's not. Postpartum blues occur now. But postpartum blues, you tell, this is the same mom that said she was going to go natural. She is not going to have postpartum blues. Not her. She's going to be the most perfect mother and the most perfect woman. You just wait and see. And my answer is, yeah, sure. She is so exhausted. So is dad. She wants to go to sleep, but she doesn't know. Is the baby asleep? There goes the epidural. All of a sudden the pain comes back, especially down the perineum. She is starving now. So now she says, what do you mean I can't get out of bed without help? What do you mean I got to sleep with my baby in the bed? You know she can't get out of bed without help the first time, right? She needs your help because just in case she has this postural hypotension. She says, what do you mean I can't? What do you mean I can't sleep with my baby in the bed? What do you mean I can't prop the bottle? Why am I so weak? She doesn't get it. I'm hungry. There goes the epidural. Everything is wrong now. So now she says, please don't lie to me. I don't feel like a Madonna. Please don't tell me that I look like her when I know for a fact that I look like her. Life is awful. Life is not good. Okay? So your mission now as nurses, you have a mission impossible. So your job, should you choose to accept it, is to overthrow a small nation's insane ruler and reestablish sanity. And the State Department and your hospital will deny any knowledge of your existence should you fail or get caught. And this tape self-destructs in 5 seconds. No, it doesn't. No, it doesn't. So how do you do this? How do you reestablish sanity? How do you do it? Well, you know she's got a lot of problems. She hurts. She can't pee properly. She's constipated. I'm walking like a duck. My milk won't come in. My breasts hurt. Everything hurts. Everything's wrong. So what is your job? Well, your job is to help her through this. This is how you help her establish her sanity. This is postpartum, and guess what? We all go through it. No matter how much we say to ourselves we're not going to go through it, we're going to. Every single one of us goes through a certain amount of this postpartum blues to certain extent. Okay, some less than others, but certainly we all do it. So here's weathering the storm. Okay, this is the challenge for the nurses. How do we do it? Well, we help her by checking the fundus, right? We want to reestablish everything, bring her back to normal. So we massage the fundus. We check that episiotomy. Basically, what are we doing? We are fussing around her, aren't we? We are fussing around her because right now she thinks everything is wrong. I can't pee. Now I'm constipated. I'm walking like a duck. Everything hurts. So when you go in and you give her all this TLC, what are you doing? You're telling her you care. You're telling her that there's somebody here who cares, and we understand. We understand this. And we're checking her lochia, and we're checking her urine output and her breasts, and we're giving her warm compresses if she's breastfeeding, and we're giving her cold compresses if she's deciding not to feed. We're doing pericare on her, and we're teaching her how to do pericare. And we're teaching her a lot of things. Okay? This doesn't just go away in spite of what we do. In spite of everything that we do to help mom, it doesn't go away right away. Dad is now confused because he doesn't know what's going on. Hormonal changes occur, and they affect her moods. And he thought, what is this? You know, he can't get it. He thinks his wife is going nuts. He thinks maybe he's going nuts. So now you need to get help for them all. Now, you may need to call social work. Sometimes you need to do that. But a lot of times you call pastoral care. You know, their pastor, their minister, their rabbi, whoever. You get the help for them that they need because they're going to need this to weather the storm. All right, so got that? We're all happy. Now let's go on to some more serious issues. All right, nobody's allowed to smile for the next hour. Okay. Let's talk about some complications of pregnancy. Yesterday I did not cover hepatitis because I said I was going to do more today. So we're going to talk about hepatitis. We're going to talk a little bit more about PIH, HIV, and drug abuse. What is hepatitis? Well, hepatitis is a viral infection, and it lives in the viral infection in the liver. It's not in your book. It is not in your book. Don't rustle. Okay? This is where you need to get pen and paper and write. Hepatitis is a viral infection. It affects the liver. You may or may not have prodromal syndromes. And what's a prodromal syndrome? Well, a prodromal syndrome is, generalized malaise, a little fever, okay, a little kind of nothing. That's a prodromal syndrome. Little ache and pain. Hepatitis is a major cause of death in third world countries, and I'm talking all the hepatitis put together. It can occur at any time during the pregnancy, and you may or may not have jaundice with hepatitis. And I did say that yesterday, that you may or may not, have jaundice in the pregnancy. It can, jaundice with hepatitis. Okay? It can occur, though, at any time during the pregnancy. All right, we've got some generalized hepatitis symptoms. And we talked about prodromal earlier, okay, and we talked about, I'll go back, prodromal symptoms are just the generalized malaise kinds of things. The achy, the aches, the pains, okay, the flu-like symptomology, those are prodromal. With hepatitis, remember it's itis. You see hepatitis, so it's itis at the end. So what are you seeing therefore? It's an inflammation, isn't it? You can also see some form of arthralgias, and what's that? Pain in the joints. You can sometimes see rashes. You might see light stools and dark urine, and why is that? Because of the bili, right? The bilirubin. Okay, it's bilirubin that causes your stool to become black. But if there's a blockage somewhere where the bilirubin cannot get to your intestine, then the bile or the bilirubin stays in your bloodstream, and it turns your urine dark, and therefore your stools stay light. Your liver function tests are going to be abnormal. You may have jaundice, you may be anorexic, you might see nausea and vomiting and some abdominal pain. Those are generalized hepatitis symptoms. Okay,